So good morning. I want to present today again our resident Souza da Silva. He will proceed with his talk. We heard last year about surgical indications in acute pancreatitis. Today we will focus on the topic, is there a place for surgery and when in chronic pancreatitis? Please go ahead.
Thank you, Chris, for introduction. Good morning, everybody. I welcome you and I'm pleased to go on with my talk that I had last week. Topic, as he said, is a place for surgical therapy in pancreatitis. Today it's about chronic pancreatitis. We will start with the indication for surgical therapy, then we'll move on to the conservative and minimal invasive therapy options, and at the end we will have a focus on the surgical therapy options. So, if somebody has chronic abdominal pain that is resistant to extensive analgesic therapy and has a devastating impact in daily quality of life, and he failed medical therapy, that is the constellation where you can say surgery is indicated. So, briefly, you can say surgery is for patients who fail medical therapy, but also as a first-line therapy if malignancy is suspected or proven. A quick reminder, diagnosis of chronic pancreatitis is done by imaging, endosonography, MRI or CAT scan. Clinic is variable. You can have chronic abdominal pain. At a late phase of the disease, you can have steatorrhea or also malabsorption with vitamin missing, or you can also have weight loss. And there are some functional tests that you can use, but they are not indicated in primary diagnostics. Sometimes you just have a very interesting plain abdominal radiograph, like you can see here, with many calcifications, which are often in chronic pancreatitis. So let's move on. The supportive or conservative therapy has many different parts. First, a reminder again, what is the most common etiology for chronic pancreatitis? It is in 70 to 90% alcohol. You have the idiopathic pancreatitis, about 20 to 30%. And now we'll start learning more and more the hereditary, or also called genetic pancreatitis. You see there some mutation loci. There are always more and more that we are learning about them, and some of the idiopathic pancreatitis in the future will be defined as hereditary pancreatitis. So what are the different options? Well, dietary change, most important, mandatory, is cessation of alcohol consumption and of smoking. You should follow a low-fat diet. Then if needed, a replacement of exocrine pancreatic enzymes. We use Creon, which has all the three important classes. We have the amylase, the lipase, most important, and protease. Then the supportive medication, use of a proton pump inhibitor to control stomach acidity. And if patients show osteoporosis or osteopenia, you should supplement vitamin D. As you know, it's a fat-soluble vitamin. And then in a late onset of late progress of a disease, if you have diabetes mellitus, of course, you have to manage this. Let's go on to the minimal invasive therapy options. There are the endoscopic treatments, and there are minimal invasive treatment options directly for pain, where you address the nerve or the celiac ganglion. So endoscopic treatment, you can put a drainage, you can put a stand with or without lithotripsy, percutaneous or locally. It's most used in patients who are unfit for surgery. But it's important to know it's not indicated for a severe course of chronic pancreatitis with severe chronic abdominal pain as definitive therapy, because you have there is the need of multiple interventions, and almost half of the patients subsequently require surgery. The place for endoscopic therapy is if you have a mild clinic and you have a cingulary stone close to the papilla fatri. So not indicated in the cases we are talking about. Then the minimal invasive therapy for pain control, we have, for example, endosonography guided or percutaneous CAT scan guided celiac nerve block, where you inject mostly alcoholic solution to kill the nerves of the celiac plexus, or you can address with a surgical fashion a thoracoscopic splanchniectomy. Data there is really short. There are no randomized controlled trials, and response rates range from low 20 to up to 90%. It's not indicated as a primary therapy, also because it's associated with severe complications, as you can imagine, putting a needle close to those important structures. So what is the evidence we have? We have little evidence, but we have some. 2012, Ali et al. Could show in a Cochrane systematic review where they looked up to 2,000 and some publications looking for randomized controlled trials. They could find 2 trials where they compared endoscopic versus surgical therapy for chronic pain in chronic pancreatitis. So let's see what they found out or what they could show. The most recent one was published in 2007 in the New England Journal of Medicine by Kayan et al., comparing 19 patients treated endoscopically versus 20 surgically, either endoscopic transampulary drainage versus open pancreatic jejunostomy. And what did they find? If you check 2 years after the intervention, 24 months, in the It's Picky pain score, I can explain you that in the discussion part. Low means 0 points, you have no pain, you have no frequency of onset of pain, you have no pain medication, and you can go to work. And 100 in these 4 categories means always the worst, and then you divide it through 4. So surgical results was about 25, the pointage or the points, and the endoscopic therapy was around 50. So they concluded that surgical drainage of pancreatic duct was more effective than endoscopic treatment. And the other randomized controlled trial was done 4 years before, published in Endoscopy in 2003 by Dite et al. They compared 36 patients in each group, either endoscopic sphincterotomy with stenting and or stone removal versus surgical resection or drainage. We will come to that part later on. And what could they show? Interestingly, after 1 year, nearly no difference. But if you look at 5 years, you will see that in this surgery group, nearly 37% have a complete absence of pain, while in the endoscopy group, nearly 35% have no success. So they concluded surgery is superior to endotherapy for long-term pain reduction. Let's go on. Surgery. So what are the goals of surgery? 2 main goals. First, to reach durable pain relief, and second, to preserve as much functional pancreatic tissue as possible. We have 2 main strategies that cross over in the middle. You have on the left side the resection procedure. So if you address the head, it's the Whipple procedure, it's the Baker procedure, the Burn modification, etc. If you address the pancreatic tail, the pancreas tail, it's the left or the distal pancreatectomy, or it can even go up to a total pancreatectomy with or without islet cell autotransplantation. On the drainage side, you have the Partington-Rochelle procedure. It's a modified Pusto procedure, meaning you drain the whole pancreatic duct by opening it longitudinally on the ventral aspect, but you leave the head by itself. You don't resect, you don't take tissue out there. We will see it later on. And a mixture is the Frey procedure, where you open the pancreatic duct longitudinally, but in the head you make a partial nucleectomy, or you just resect the tissue. I will tell you also what's the idea behind it. Respectively, we can start now. We don't really understand what produces chronic pain on chronic pancreatitis. There are 2 main ideas. First, easy to explain, and is a local inflammation with local ischemia in the small tissue area. You don't see it maybe. And the other one is a high pressure zone in the main pancreatic duct or in the side branches. So this is what leads to this tailored approach. This is a decision tree in the American HPBA Association in the book of 2018, where it's considering chronic pancreatitis with head involvement. So chronic pancreatitis mostly affects the whole pancreas. We leave out those seldom cases where it's only on the tail. So if the head is involved, what do you have to know? First, the duct size. If it's less than 7 millimeters, You think it's maybe a duct problem, but mainly it must be also a problem of the head. It's said that the head is the pacemaker of pain. So you have some kind of trouble in the tissue there. So all of the procedures have to address the head. So is there suspicion of malignancy? You proceed with the Whipple procedure, as you see on the left. If you have no confirmed or suspicion for malignancy, you have to check, are there multiple strictures in the duct? If so, you have to address also the duct. You can't just go to the head because maybe one of those strictures will be symptomatic. It's a so-called chain of lake sign that you can see. If that's the case, you have to perform a Frey procedure. You address the head, but also by opening the duct, you address the duct with a drainage. If not, you can proceed if you want just with the bigger procedure. That's an isolated resection of the pancreatic head, leaving a margin around the duodenum, and then creating an end-to-end and the end-to-side pancreaticojejunostomy. We don't go further into that topic, but that's the other option. If the duct is large, you still are not sure if the head is the problem, the tissue, the local tissue over there. So you have to think, is the head enlarged? Does it speak for a problem there? If it's more than 4 centimeters, again, you have to choose a procedure where you address the head. If it's less than 4 centimeters, you can think, okay, maybe it's just a duct that's involved. Let's do the most or the least invasive procedure, which they call Pusto, but it's a modified Pusto or a Partington-Rochelle procedure. We will see that also later on, where you just open longitudinally the duct and you don't go really into the zone of the head and you make no tissue resection. If this fails, you proceed with a salvage therapy, meaning you complete to a total pancreatectomy with or without islet cell autotransplantation. So here's some pictures of the procedure, just to have again a reminder. You have here the opening of the lesser sac and the mobilization of the right colonic flexure. So you have an onside of the ventral aspect of the whole pancreas. Here is the extended Kocher maneuver. You have control and mobilization of the pancreatic head. Here you start dissecting the stomach, and in the next step you see the dissection of the pancreas on the superior mesenteric vein and confluence of the porta or porta, and also mobilization of the duodenum. We have some pictures of our own clinic. Here you see a very nice picture with the portal vein here. You see here the transection line of the pancreas. In this vessel loop is the arteria hepatica propria, and here a very nice specimen. You see the pylorus of the stomach, the duodenum, and the pancreatic head. Construction is done with end-to-side pancreaticojejunostomy, end-to-side hepaticojejunostomy, and a side-to-side gastrojejunostomy with the foot point anastomosis of the omega loop. Here a very nice picture also from our OR, where you see how the stitches are done full thickness for the preparation for the pancreaticojejunostomy, taking here the dilated pancreatic duct. Let's go quickly to the Frey procedure. Here you locate the duct with the syringe. You start opening it from the tail alongside until the head. You check if the papilla fatui is passable with the Kelly clamp. And this is another overview how it looks like when you're finished. You have here the drainage of the whole duct, and here you have resection of pancreatic head tissue. Reconstruction is made by a side-to-side pancreaticojejunostomy and a footprint anastomosis. That's how it looks also here in the overview. The Partington-Rochelle, as I told you, is similar to a Frey procedure, just a minimal version of it. You don't go really into the head, you don't take any tissue away over here, so it looks like that. On the last 2 minutes left, I want to talk about total pancreatectomy with or without islet cell autotransplantation. When is it indicated? When you have a young patient with a genetic, let's say, let's call it genetic pancreatitis. You see again those LOTC where you have mutation, or if the patient is young and he has a minimal change pancreatitis, meaning he has a small duct, minimal calcific burden. We don't know what's the reason for the pancreatitis. Maybe in some years we will also put some of those patients or those categories into the genetic pancreatitis. Why should you consider total pancreatectomy? While chronic pancreatitis has, in general, higher risk for pancreatic cancer compared to the normal population, 3, 4, 5 times, those mutations higher the risk about 30 to 70 times. So if you have a 20 or 30-year-old patient, you want to take all the tissue out so he doesn't suffer of pancreatic cancer. And of course, the other indication is salvage therapy, as I said, if the other surgical therapies don't succeed. Interesting fact, if you have a patient that already is diabetic and you perform a total pancreatectomy, there is a chance that you might do a islet cell autotransplantation if he reaches the cutoff of stimulated C-peptide over 0.7 nanomole per liter, meaning he has enough function of those beta cells. Well, it could look like this. Or it looks like this. This is the part of the resection, a total pancreatectomy. You take out the pancreas, you proceed it, make an autodigestion, harvest the cells, and then you make an autotransplantation over the portal vein or any having access to it, like a mesenteric superior or inferior vein. And you see the cells will find a new place in the liver and start working. Before anybody asks, I have found little data to that, but after 2 years, if you harvest more than 300,000 cells, that's the cutoff, more than 75% of the patient don't need insulin. I'm not talking about oral antidiabetics, but insulin. So it has a high success rate if it works well. 50 to 60% achieve narcotic independence. So you will ask, what is with the rest? We don't know. Maybe they have pain memory. It's complex. We don't know why they still have pain. An important fact as well, if there is a comorbid hepatic disease, it's a relative contraindication because this injection makes a transient embolization of some end branches of the portal vein system. So if you have already a portal hypertension, it can make it even worse and you can have a liver failure. So you have to consider that. Let me reach the take-home message. Surgery is superior to endoscopic or interventional treatment for persisting pain in chronic pancreatitis. And patient-tailored choice of a surgical procedure depends on pancreatic parenchyma, on duct morphology, and patient characteristics. Thank you for your attention.
Yeah, Richard, thank you very much for this follow-up talk about chronic pancreatitis. Here, very well done, complex topic and very low level of evidence, although you show a few randomized controlled trials. I mean, in Zurich, we are known from many years not to go for surgery with the previous chief of gastroenterology, Professor Amann, who published a landmark paper. We influenced a lot this treatment in the 80s with the theorists to say that don't operate, just wait. There is a burnout phenomenon, meaning that with time the pain goes away because the pancreas is completely destroyed. This was not confirmed in some way, but there's a strong impact on indication for surgery in this disease. You highlight very clearly the indication, or the only one, is really pain. Suspicion of tumor may happen, but that's relatively rare. I mean, this is a risk factor for cancer, but it's an association that's quite rare. A few points maybe here. The guideline you show, it's at the it's a level 5. I mean, there's not much data. I don't know, where was that published?
This was in the American HPBA book about...
It's in a book?
Yes.
Okay, I'm not even aware about these guidelines, which I should. I'm not saying it's wrong, but it's rather an institution as a Ghana. We are not following these guidelines in some way. Maybe it's useful, but we are not at all. The Whipple operation is very rarely indicated. Why? Because it is a very high-risk procedure. It's much more difficult or much high risk of complication during the removal of the head of the pancreas, because there is very often with the portal vein a lot of adhesion, difficult to separate, and every centers who do a lot of this operation has experienced some unpleasant bleeding during this. So this is, although the risk of leak after that is less because the pancreas is hard, these are pretty difficult operations. Now, what do we do in different centers? I think the reality, assuming the indication is correct, and the indication I think uses pain, refractory to medical treatment is also a bit subjective. You know, if you can have patients with a lot of alcohol and morphine, they do well. Maybe surgery is still better, even though they could be controlled. So that's not clearly defined, but it depends on the local expertise and the referral. These patients are seen by gastroenterologists almost everywhere in the world, and the gastroenterologist is the gatekeeper, and they decide whether they refer to surgery, whether they put stent, etc. And I'm suspicious that despite these pretty clear data published in the New England and endoscopy, although sample size was that clearly favor surgery, that many of these cases are not even discussed with the surgeon. They put a stent, and then you see the patient after I don't know how many stent or infection to the surgeon, which only complicate surgery. This is an obvious bias. So the local expertise play a major role here from the expertise of the gastroenterologists or surgeons. We don't operate many, very few centers do many of this. So this is also often not attractive, particularly for general surgeon. That should be certainly done by people who experience in a pancreas surgery in some way here. As I say, I mean, whether you do the fray, you do the burn, or you do other variant beggar, I think this is not so relevant, and I don't think that make a major role. There is a principle here, and that's the one we apply. We think, or that the pain, there is like a pacemaker in the head of the pancreas. There's strong suspicion for that. Therefore, you need to remove the part of the head of the pancreas, not in a Whipple, but in an extended opening of the pancreatic duct, which should be large. When it's small, this operation doesn't work. So it has to be some dilatation that you can remove stone, and then you just remove part of the head and include the head in the anastomosis, whatever name is given. I think is an operation that most people are doing. And you sure, I think the gastroenterologists do not know that in 50%, or if sometimes more, there is a complete relief of the pain. So this is a very successful operation when it's indicated, and I believe that unfortunately, not many patients may benefit from this surgery. So I think I stop here. I don't know if there is any question, or if Chris wants to say something here about chronic pancreatitis. He was the mentor for this talk.
It was a good talk, very nicely done. I think I have just 2 comments. In chronic pancreatitis, we always have a higher risk of cancer. So if there's any suspicion that we have cancer, we should try to resect anyway, if we do a total or just a pancreatectomy, but we should choose a resection policy. So any suspicion of cancer, just go for complete resection. And then there's another thing I want to point out, which we didn't touch so much, is the timing of surgery, which is quite difficult in those patients. And there's a new publication in JAMA, came out this year, where they looked at people who are on pain medications, opioids, less than 6 weeks, and they already went for surgery, and those who were treated for half a year on opioids and then had their surgery done. It's only 88 patients, 44 randomized. That's a randomized trial, and even there we see that the early surgery is much beneficial to those patients. They will have less this opioid use for a long time, and also after the surgery they will benefit and have a better relief of pain if they're operated early on. That's the 2 things.
No questions. So Richard, that means your talk was perfect. Thank you.
Thank you.